just like to explain that the next session is actually going to be a video presentation. And whilst it isn't about specifically SEREN Connect, we felt that as we were bringing together colleagues from both paediatric and adult services, then a discussion on working together, pulling and pooling resources and delivering results on the cheap, in inverted commas, as will be explained in the presentation, will be beneficial. Unfortunately, our guests couldn't be here today, but we've got this pre-recorded presentation from the Wrexham Young Adult team. So if I can just introduce the presenters, hopefully most of you will have heard of both of them. So Dr. Steve Stanaway is a consultant physician and endocrinologist, and Steve started the Wrexham Young Adult Clinic in 2005, initially with only one diabetes specialist nurse, but over this time has expanded to include a specialist dietitian and a dedicated clinical psychologist. Steve and his team's motto in terms of successfully working with young adults is to keep them coming. And I think that's probably a sentiment that we all would support, no matter how difficult this can be at times. Dr. Rose Stewart, as many of you know, is a multi-award winning consultant clinical psychologist in North Wales, and she's the author of the Talking Type 1 range of booklets, which hopefully you've all seen and are already using within your services. And she has a particular interest in working with young adults. I think that when a lot of us have looked at how we're running our moving to young adults or transitional, whatever you want to call it, the Wrexham model has been famous for years. So I think it'd be really interesting to hear their presentation. So please, could you press play? Thank you.
Hi everyone, thanks very much for inviting us to talk at this meeting. We've been asked to talk to you a little bit about setting up a transitional service that should hopefully enhance the care of young people, and doing it very much on the cheap. In fact, what we can tell you is we can do it for no money at all using your existing resources. So I'm going to present the first half of this presentation, then my colleague Rose Stewart, who you may know as our consultant clinical psychologist, is going to take over from me. What we're going to talk about then is what's the problems with young adults, why do we have to give them a special attention, what our mission is in our own service here, and perhaps what it should be throughout other services, the Wrexham model that we use, and that we've used for transition for about 10 years now, what was missing, and then the answer obviously is psychology, getting psychology involved, and how the Wrexham model looks now. So, what is it with young adults? Well, how long have you got? And we all know what it is with young adults, particularly those of us who treat them, or perhaps more particularly have even brought them up. But just to kind of illustrate what it is with young adults with diabetes, this graph illustrates it very well. This is HbA1c numbers on average of about 10,000 patients based on age. You can see there's this quite marked peak in people in their late teens, early 20s, which just seems to come down as life goes on. To more what we call more acceptable levels. And while there may be lots of reasons for that, I think a big part of the reason for that is in relation to age and life stresses and life events and maturity, etc., etc. You can see a really similar graph here if you look at number of admissions with DKA in different age groups, and you can see that perhaps not surprisingly that curve pretty much mirrors the other one. High HbA1cs tend to more at risk of DKA. And again, it's the same age group. So no big shock to anyone on that. But it's something that we do need to pay attention to on the basis that if we don't get good control, there's obviously risk of complications and there's the risks of severe emergencies like DKA. But how do we do it? And that is really, really key, because they are not the easiest bunch to work with. So just to put it in figures, the incidence of DKA is actually double for young adults compared to adults of an older age. So if we explore a little bit more then into what it is with young people that make life special at that age, what we know is that they undergo an awful lot of change. And change is something that always causes disruption, and disruption with diabetes is never usually a good thing. young adults always seem to have very dramatic lives, don't they? They always seem to be, everything that happens is a big deal. It's a big event. It takes a lot of processing and working through, and things that as you get older and more mature, you would just brush off, laugh at even, to them are big and complex problems. Add to that the brain maturity, etc., and you end up with a situation where people are very labile emotions. So again, handling stress and change can be quite difficult. When people are in the middle of forming their own identities, they don't really know what they think about certain things. All they know is that certain things seem to be happening to them. And that's quite a difficult time to be in. We all remember that, don't we? The world is changing. We need to think not only about the world in general. Social media has to be mentioned here, doesn't it? And the fact that, you know, they've been through COVID more latterly, but also their world is changing dramatically as they go through this period of growing up. They move out from the very pastoral care in school to perhaps less pastoral sixth form services, going to university, college, starting work, pulling away from the family support network, etc., etc. And that has a massive impact on things as well. It's other things to process and to take into account, and many things obviously that get in the way of treating the diabetes, not surprisingly. And that's no crime. It's just that we need to somehow find a place for the diabetes in there and support it as best as we can. Big decisions are needed, which feeds into all of that university work, etc., etc. And of course, young adults are particularly prone to making poor decisions. We think of them as adults, we call them adults, but we know absolutely categorically that neurologically they're not adults yet in the truest of form. They're kind of half children in big bodies, and that doesn't allow always for the best decision making, and we have to tolerate that. Those of us again that have been parents will know this, but this risky behaviour is something that will play out in the diabetes side of their life as well, and we have to acknowledge some of that, I think. Throw in the extra efforts of drugs and alcohol to get a grip of people, and you can see the heady mix. But there's also, if you happen to live with diabetes, the issue of transitioning out of paediatric services. And that's a big event for people. It's actually a big event, not only for the young person, but it's a big event for the parents as well, which I think sometimes plays out in the stress field that lives within the household. And I think that's something that we actually can do something about, and we can make that as smooth and as easy as possible. Then it's one thing perhaps we can de-stress the whole situation about. So our mission, some years ago, I suppose, really, and we've been on a long journey with this, was to try and fix the transitional process, and to do it as per NHS with no additional funding. So how did we start our service? Well, we started our young adult clinic in 2005, and that was a bit of a cobbled together setup. We didn't have one in this hospital at that point, but we figured we needed one, and we decided we should base it around a simple ethos, which was keep them coming back. If you lose a patient at that early age, 17, 18, 19, whatever, it's very hard to get them back into the service. And we've all seen the consequence of people who completely disengage from services and go away and have awful control for a number of years, and they roll back up in their late 20s with all sorts of complications. We've all been there. It's the worst case scenario, but it's not pretty when it's seen. And we wanted to make sure our whole ethos was keeping people coming back to clinic. That way we had a chance to help and influence. It's hugely important, and I cannot stress enough the need for your young person's clinic, well, any clinic really, but particularly a person's clinic, to not be a place that they fear. There is no shaming, there is no blaming. Many of us of my age and older will remember working in clinics when we were trainees, where the whole culture seemed to be to shame people into trying to gain better control of their diabetes. No allowance was given for people's stage of life or state of life. And it's completely destructive, in my opinion, and I think the world has moved on. But in this age group, it's super important. So when we started our clinic, we said, right, no fear, no shame, no blame, no judgment. This is not what it's about. It's about engagement with people who are going through enough. We want to try and understand people, and a lot of what we decided we would talk about in clinic probably would not be directly diabetes. It would be about people's lives. Understanding people's lives put us in a much better position to be able to assist with those lives. And we also recognise and try to really play out the importance of relationships, i.e. relationships with us, the team that was involved, and at the time it was me and a diabetes nurse, and we would see the patients together and try and establish a relationship that was one of trust and I suppose a little bit of feeling that we didn't want to let them down, perhaps they didn't want to let us down, if that makes sense. But also understand relationships within the other relationships in the life of the young person we were seeing, and understanding those and playing to their strengths, or perhaps trying to warn where weaknesses or destructive relationships seem to be in place as well. We tried to make sure relationships were part of what we did. So we evolved that later. That was how we started out. And we evolved that later into something that was stronger still, because we wanted to really look at the transition. So at the time, transition in our service was literally, I would wander over to the last paediatric clinic, say hello, meet the patient for the first time and their parent, and then the next time they were seen would be over in the adult diabetes centre with me and our diabetes nurse, which was a one-stop transition, which wasn't really a transition at all. It was just a block change. So we decided the transition service needed looking at next. In 2012, we came up with our new model, which involved joint service ownership between paediatrics and adult diabetes. We reinforced really something we'd actually had before, but we had a no DNA discharge policy. If people don't come to clinic, we don't discharge them, because again, that way we've lost completely. Nobody wins from that. And we introduced, we'll keep trying to engage. Now, we may fail, and you might say, well, you're wasting slots, but ultimately, I think that's better. In a lot of cases, we did manage to engage at some point and make some kind of established relationship with people if we just persisted. And we also tried to really push the point of individualised communication, obviously, because people are individuals and very much need to be treated as such. So what we started this new process with was a paediatric diabetes team. Well, no surprise, we already had one of those. A named adult diabetes consultant, DSN and dietitian. Well, we already had those. There was no investment in that. That was already established. And we had we really do have a genius medical secretary, Sharon, who we depend on very heavily for this. But again, we already had her. No investment was needed. And using those resources exactly as they stood, we just simply changed the way we worked and just looked at the way in which we interacted. The model we came up with, and some of you might have heard this presentation from us before, but just to reiterate it, the transition process starts as the young person enters year 12, which is the year after GCSEs. So we would have our first transitional clinic at that point, and it's usually in the winter, often in the December. And what happens there is the adult team, that's me and the DSN and the dietitian, will go over to the paediatric building. There'll be a clinic that's been pulled together that consists of all the next cohort of young people to be handed over. Will come to one clinic and we will meet them. The clinic will be led by the consultant paediatrician and the paediatric nurse, but we will be in the room with them. And it's just really an opportunity for us to say hello with the young person and their parents, that are usually still there at that point, just to see us, to see that we're quite normal. And we make an effort, obviously, to be quite friendly. We don't say a huge amount, but we take some interest. We might just pick up on something they say in conversation, and like what football team they support or something, and just chat through that. Just to say that we're quite human and quite normal. Then we go away, and we do exactly the same thing again in the next summer. We call that our T2 or Transition 2 clinic. So we go over again to paediatrics. The same cohort of youngsters will be put into that clinic, and we'll do exactly the same thing again. We might try and engage a little bit more at that clinic, just say a few more things, maybe even get stuck in a little bit to the care and treatment if that's under discussion. But it's the same setup. We're all in the same room together. And it's at that point that the consultant paediatrician says goodbye to the patient and says and explains again, it's already been explained once, but explains again that he'll now be stepping out and that I will become their consultant. But the paediatric nurses will remain their nurses for another year. We meet the same group of patients again in what we call our T3 clinic, and this will be in the autumn of their year 13 at school or equivalent if they've left school. And this will be their first clinic in the adult diabetes centre. So we changed the setting at that point, and they come and meet us at the adult clinic. We go through the normal processes of how we conduct that clinic, with a finger prick HbA1c when they come in, subject to their consent, of course, and we meet them again in a room. But this time in the room, there will be me. There will be our paediatric diabetes nurse who will come over, because they are all she's at our place at the moment, is still very much their main point of contact. Our adult diabetes nurse will also be in the room. And of course, the young person's already met her at the previous clinics. And our psychologist will also introduce herself at that opportunity. So we can just explain that this is how we work the clinic. We work it as an integrated clinic, more of which later from Rose. So at this point, I'm now in charge of care, and we have a friendly and hopefully very constructive meeting at that first meeting in the adult centre. We repeat that again in the winter, usually in the March of that year 13 school year or equivalent, same thing, and we do it again in the summer, usually in the July. And it's at that point that the paediatric DSN will say goodbye to the patient, and full care will be handed over to the adult team. But when I say adult team, it's the team, those of us that do the young adult clinic. And at that point, we say, right, so your next clinic will be in exactly the same room, exactly the same day of the week. It'll simply be, the paediatric people won't be here anymore, and we'll keep you in this young adult clinic until the age of 25. We've just recently managed to expand it from 23 to 25 by introducing some new clinics, which is all to do with job planning me, and hasn't cost any money. And we will extend that beyond 25 if they're still in full-time education, which is quite rare they are once they get to that age. And at that point, we bring them into that young person's clinic. So how we started is, as explained before, really, and then we moved over to the new transitional model, which we've been doing for about 10 years. And these are numbers taken from a few years ago, but we seem to think things are working. Our attendance rates at the clinic were 75 to 79%. I think, if I'm quite honest with you, they've dropped off a bit of late, and I think that might have something to do with COVID, but we're going to start looking into that a little bit. But we were achieving regular attendance rates of 79, up to 79%, which is as high as anything actually I could find published. And I think it was about this engagement, this ease of handover, that maybe we weren't too threatening or too new when they came over to our care. But I will say it is also about the way in which you engage people. You've got to engage people well. If young people are not your thing, you probably shouldn't be doing a young person's clinic, because I think you'll just create a tension in somewhere, and that might not be particularly constructive. And I'm going to hand over to Rose now, who's going to explain the next step of what we did, because I've mentioned that we have Rose in the clinic because we haven't always had a psychologist in the clinic, and I'm going to explain to you how we brought that in. Some noise while we change chairs.
Very technical. All right, thank you, Steve. So I'm Rose, and I am the psychologist with the Young Adult Service. And many of you will already know that when I came into the service, I also came in for free. So I was part of a pilot project where I was borrowed from a different service within our health board. And one of the key things that really helped with that was that Steve and Julie Lewis, our clinical lead, had lots and lots of information about unscheduled care, and particularly looking at admission rates for young people. So they had that data ready to go. So when there was a team that was looking at particularly projects to reduce unscheduled care, that data was there, and it helped the service make the case to have a psychology pilot project, which is where I came from. So we started this pilot project looking at what psychological support for young adults could do, particularly around admissions. But what we found very, very quickly was that something that we'd initially introduced as a strategy to help young people reduce anxiety, to get to know me, which was me sitting in the young adult clinics, what we found really quickly was that actually sitting in the clinics was incredibly powerful, and it made an integrated clinic that enabled us to offer a lot more in the way of holistic care for young people. And crucially, what it meant was that every young person got some access to psychology. So that was something that's been really key in our learning. And again, having an integrated psychologist costs exactly the same as having a psychologist off in another building. So not something that costs huge amounts of additional money. We found that these advantages of integration have really spread right across the team. So we found that it massively reduces stigma and anxiety, and it means that psychology appointments are far better attended than if I were to be off in another building. It's really increased the availability because it means that I am well aware of our young people before these issues start to arise. I know when they're coming up through transition. I've been able to liaise with the PEDS team. I know if this is somebody that might be a bit more vulnerable, that we need to keep an eye on them. And it means that quite often, because our young people are more willing to ask for help earlier on before a huge crisis emerges, that the input that they need from me is shorter than were it a massive emergency where things had gotten really complex. So again, that helps with my throughput and my caseload. And we found that it really increases safety. So as a psychologist, didn't get trained in diabetes when I was qualifying. So it was incredibly important for me to have that training from the team. I've learned so much from sitting in clinic. And we've also been able to have some bilateral training there as well, where I've been able to talk to the team about eating disorders, about neurodevelopmental issues, all of these things that really regularly show up in diabetes care, but we wouldn't regularly think about unless we've got psychologists on the team. And it means that we've been able to have joint management where it's needed and to have that consistent approach. So particularly when young people have interpersonal difficulties, where team splitting might be an issue, having those integrated clinics is really helpful to make sure that we're all singing from the same hymn sheet and that person has that safe, consistent approach from the team. And it's also meant that being part of the diabetes team, that we've been able to look at much more in the way of grey areas of work. So looking at consultation, supervision, research and audit projects. It's an extra person on the team, but it's also expanded what we're able to do as a team in looking at new areas of practice. So this is kind of where we are up to now. So this model was established in 2016 and we're continuing to build on it. So we've got this integrated psychology support. We're screening for distress in all of our young people. We're really working hard with education and support resources. So things like the SEREN Connect program is something that we're working really hard to implement within our team. And we're looking at strategies that will help young people to access that education. Just really quickly to let you know, in case you don't already, we have published an All Wales document on diabetes psychology, which includes everything that you need to know to put in a business case. So if you haven't seen this document already and you're looking to get psychology for your young adult service, please download this because it will give you all the information that you need. You can also use the information from your Type 1 peer review. And the recent GIRFT guidance that NHS England published last year makes specific recommendations about psychology for young adults. So these are all really useful documents to quote within any business cases that you're making. So what have we learned so far in Wrexham? It really doesn't have to cost money. You can make these improvements without waiting for funding. Committed clinicians can really make a difference here. And I think what Steve's been able to do with no funding at all is phenomenal. So please don't let staffing and funding hold you back. You can start to make changes today. And if you put those relationships at the heart of your service, the results will follow. Having that attachment within the service ethos makes such a big difference and can really help young people get through that roller coaster in the early years. In terms of psychology support, data is absolutely key. Having that data to establish a case of need at the beginning, but also making sure if you are using pilot projects that you have a really robust evaluation system so that you can achieve further funding. And if you do get psychology into your services, integrated is absolutely best. You will get a better service, you will get a much happier psychologist, and you will get a improved and skilled up team as a result. None of that costs additional money and it has huge additional benefits. So yeah, again, we're really sorry we can't be there today, but please, if you want any further advice or guidance, please do contact us. We're always more than willing to help with this, and we really look forward to this expanding right across Wales. And we will see you soon. Thank you. Good.
So sadly, we can't do questions and answers about that, but we could have 5 minutes just discussion if anyone has anything, you know, any great examples of how they're working. Joe, I think, hang on, I think Nessia might be.
I don't mind. I was just going to say, me, that was so helpful, looking about the whole and about ways to overcome the barriers and challenges. I think obviously the Wrexham service just highlights that resources, money isn't always needed. It's about working differently, and it's having those joined up conversations and trying to overcome those hurdles. But money isn't, it's nice to have, it's helpful, but it isn't always necessary to be able to do things different. And it's having that outward look and opportunities to discuss with people just like Rose and Stephen, who've overcome those hurdles and barriers. So yeah, that for me is really good, and perhaps ticks those boxes of highlighting that funding isn't always the answer.
Yeah, the phrase I really liked was one at the end, you know, committed clinicians can make a difference, and it's the teams working together. We've got another question. Yeah.
Hi, I just wanted to ask the room really for some advice and some, if you've got any experience of this. Our transition pathway in Swansea is very similar to the Wrexham model. We've recently updated it a little bit, and what we'd love to do is to be able to follow our patients through up until they're 17, 18 years old. But a lot of our the medical staff in Swansea feel that when it comes to acute setting, once those young people are seen in acute wards in an acute environment when they're unwell, they then should cross over into adult care. And to get that kind of, if you're still the link nurse or you're still looking after that young person, but they're going to be seen in adult services, it's very difficult then. That kind of, I don't know what other services are doing about that, but that seems to be a really difficult area for us.
That's one of the areas in an Iron Bevan that we've always had an issue with that sort of crossover period. And when I proposed much more joint working many years ago when I was appointed, the resistance was, but who owns the patients and what happens with acute admissions? We used to have an adolescent ward or a young adult ward, which took patients up to their early 20s. They weren't peds. They, you know, if they were adult age, they were looked after by adult teams. But we no longer have that in our new hospital. And what we find is that they're still under our care till at least after their 17th birthday. We don't move anybody until they're over 17. So sometimes they're approaching 18 when we move them, and they struggle to get admitted under paediatrics when they come in through ED, for example, and we say, just tell them you're under peds, you know, but it's those sort of things that actually are barriers to really good transition. That
it's a real grey area, because although that might happen in medicine, then if we as PDSNs want to continue with them till they're 18, 19, if we then take a phone call from somebody in crisis, who do we liaise with? Who's the consultant that, you know, takes ownership, like you said? So we're finding that a really grey area.
I don't know if anyone else has any solutions. There's just one more question, Sian, and then Sian, please.
Yeah, it's not a solution really. It's just to say what we do. We keep them in paediatrics until they go over to adults at nearly 18. So our paediatric wards, certainly in 2 of our hospitals in the health board, will take admissions onto the paediatric ward up until they're 18 or until their last transition appointment. But one of our other hospitals, it's been a bit of a grey area, definitely. from that 16 to 18 period. But we're very lucky. We're very lucky that our peds wards will take them right up until they transition.
Sean?
I know it's similar with us as well, but in Carmarthen, the inpatient ward won't accept them after their 16th birthday because of if they need to go to, say, ITU, for instance, who takes them? And then we've had the battle where they're in limbo ultimately. So they can't go to the inpatient ward and after their 16th birthday, but they are still under our care. So we often will get, phone calls from the adult inpatients to us. So it is a massive grey area as well, really. But they don't end up there that often. But yeah, when it does, it causes some issues, really.
So I work in Iron Bevan in the same health board as Davida. And I just wanted to make the point that I think the ones who really miss out are the ones who are diagnosed brand new just after the age of 16. They come straight into adult care. We're not resourced in the same way. They haven't got as much contact with us as if they'd been in the paediatric team. We can go out to schools and colleges, but it's more difficult for us because of our other commitments. And bearing in mind, in adult care, type 1 is a tiny amount of our total population of people with diabetes. So we've spread very, very thinly. And I think that those young people really miss out. So these leaflets are used a lot for that group. That's the information they are introduced to first. So, but they do seem to...
Yeah, it's a really good point,
to be
Sean.
a missing group. And
yeah.
There's a significant number each year that are diagnosed, sort of between 16 and 18.
Hi everyone, just again a comment really. This particular dilemma I think comes up quite often, and Davida and Julia, maybe we'll look at that outside of today of what we can do. But I was, just to bring my own experience from a type 1 point of view, was I remember being admitted when I was 19, and an adult ward at 19 was so damaging. I vowed to myself I would never be admitted under unscheduled care again. I had an eating disorder for years and I just kept myself out of hospital, but I didn't keep myself very well. And so we do need, there's a big push in England to be looking at services that are up to 25, because we just don't, it's not for the lack of trying. I know everybody in the room is really stretched, but we don't cater for under 25s very well. And it is, as we've seen today, a very different period of life to everywhere else. We do bend services for the elderly, and we need to be doing that for young adults. So anybody in the room can push where you can after today. We can all push together, because it's it's really important. We do lose, we lose young people before they're 25 as well, as in they die because they're frightened to come into adult services. So we'll pick that up after today, I think, but that's definitely really important. Thank you.
There's another couple.
Hi, I'm Anna. I'm diabetes adult trainee reg, and I worked in the Gwent when they still had the young adult, the adolescent ward.
Yeah, worked well.
And it made such a difference because the paediatric nurses on there were interested in the young adults. And the problem is, in other hospitals, when you see it through their eyes, like demented patients trying to get into your bed and people screaming and this and that, actually, I don't know why anyone stays in hospital, but when you don't have you can't figure out the consequences, and it is really scarring. And also the rest of the staff forget that you're only like 19 or 22, and it's not a very nice experience. And also a lot of the time, people forget that actually having parents there or letting their friends in would make that better. But again, it all gets lost in the panic stations and fighting fires and adult services.
Hi, I haven't got type 1 diabetes, but I have got a long-term chronic condition. And as a child, I was in and out of hospital a lot. And I think there does need to be a bend in the service for up to 25, because I was put in a children's ward at the age of 19, and that's not pleasant either. And I think there's a problem here with the guidelines, because you've got specific paediatric guidelines and you've got specific adult guidelines. And that's where the panic is. Do we treat them according to the adult or to the paediatric guidelines? and then that causes a panic with staff in both of those areas.
Hi, I'm Lucy, diabetes nurse in Withybush Hospital. I just find it's a really grey area. We've got young children coming over at the age of 15 in transition into 16 because they've left education, but mentally they're just not ready for the adult service. And I just feel they're just completely thrown to us, but they're just not ready for it. So that's a real grey area, I think, also.
Hi, I work in Swansea Bay. I was just going to highlight that the issue of the age sometimes, because I know recently we had someone who was in his last year in comp, so year 11, I think that's what they are. But because he happened to be born early in the year, so he was 16 early on, he went straight into adult services, but he was still at school. And it was like, from an adult service, we couldn't really provide the support for going into schools, thinking about college, etc. So I think sometimes going by age isn't a great thing as well.
We'll take one more question from Sarah and then we'll move on if that's okay.
Thank you. I just wanted to say that I don't really understand why it's based on education, because brains continue to develop until they're into their mid-20s. An 18-year-old can't problem solve, use their language as well as we would expect an adult to. You know that their frontal lobe isn't developed as a 50-year-old would be, yet they're kind of put into an adult service where maybe the expectation is too much and we're kind of setting them up to fail, aren't we?
Yeah, and I think diabetes is probably quite unique in the demands it puts on a young person to manage their life, you know, well, every minute of every day, as is very different from many other chronic health conditions. And so I agree. I mean, it's not, I think education is used as a easy cut-off. Services in paediatrics are funded up until 16th birthday, adult services beyond 16th birthday. And there's just these areas that just seem really difficult to meld. And I don't, but Sarah, yes, let's take it up and try and do something else.
You do always come up against, well, if you can have that for diabetes, you need it for other conditions. But how many other young people are actually titrating their own drugs minute by minute sometimes throughout the day? It is it's ubiquitous. It comes into everything. And we do need to know who we speak to make that change. But we all need to keep saying the same things to the right people, and we'll write reports, and we'll get Simon on the case. He's day 2.
Yeah, Simon, put it on the list. Put it on the list. Yeah. Okay.
Thank you so much.
Yeah.
We do have an afternoon of getting your thoughts and feelings and stuff. So it's good to hear some other people on the mics as well. So please keep it up. I hope you're having a good day.
Yeah. Thank you.